Hi everyone. So let's continue with the management of cataract. So coming to the indications of for cataract surgery, usually what we say the patient is once if they cannot do their normal routine activities, that is when we will prefer cataract surgery. And there are other indications too, that is clear lens exchange, that is done in the case of refractive error. If the patient has high refractive error, then we can do clear lens exchange. And the medical indications include if the health of the eye is affected, let's say the patient has phacolytic or phacomorphic glaucoma, where in this case it will affect the optic nerve because of glaucoma, then we will do cataract surgery. There are other indications such as cataract surgery to improve the clarity of ocular media. Let's say a patient is having diabetic retinopathy, proliferative diabetic retinopathy, and we have to do PRP, which is pan-retinal photocoagulation. Then we can remove the cataract lens so that we will have a clear view of the retina, and we can go ahead with the surgery with the procedure PRP. So coming to the investigations, systemic investigations such as diabetes, hypertension, heart disease, lung disease, infections, all these things should be ruled out and should be cleared before operating. Either we should rectify the disease, or we have to ask the opinion of second opinion from the other consultants in order to proceed with the surgery, because most of the surgeries are elective and we should not take any chance. So coming to the ophthalmic point of view, visual acuity and refraction. In case of advanced cataract, if the visual acuity is poor, then we have to do PLPR, which is perception of light and projection of rays. This is done so that it's like a gross examination of how much the field of vision is, and if there is any defect in the nerve, all these things can be caught by this simple test. And yeah, that gives a rough estimation of retina and optic nerve function. Color vision and pupillary reaction to assess the optic nerve. So all these things should be done before proceeding with the surgery. This is Snellen's chart in order to find out the visual acuity. This is color vision HRS chart, and this is pupillary reaction. That's how they test it. The patient should look far ahead and we have to shine a torch. Coming to the main investigation, slit lamp examination with intraocular pressure evaluation by tonometry. Usually we use Goldman's applanation tonometer. This is the slit lamp and this is the Goldman's applanation tonometer, and this is the Myers. This is how we see, and we will estimate the pressure of the patient. We will discuss a lot about this in glaucoma chapter. And coming to gonioscopy. So if the pressure is high, or if you suspect angle closure glaucoma, if the anterior chamber depth is less, then we will go ahead with a gonioscopy. So gonioscopy is a procedure in which we will see the angles, and if needed the patient will be given peripheral iridotomies. So coming to dilated fundus examination, if everything is clear, pressure is not high, and in case after seeing gonioscopy and the angles are open, then we will do dilated fundus examination to rule out any retinal pathology. So tests for macular functions such as potential acuity meter. This is used to predict post-op visual acuity. Sometimes the patient will ask, how much will I regain vision, how much will I be able to see? So for that case we use a potential acuity meter and tell the patient that this much amount of vision you can regain. And then test for stereo acuity. Sometimes we do that in order to find out if the patient is having depth perception. Other investigations include syringing for patency of lacrimal drainage pathway, because sometimes the patient might have chronic dacryocystitis and we will not know that unless you do syringing. Sometimes we uh, press on the lacrimal duct, so that if there is any pus coming out, then we'll go ahead, we will stop doing this cataract surgery. But in case if there is patient is having chronic dacryocystitis and you proceed with the procedure, the patient might go in for endophthalmitis. We'll talk about it soon. And then we'll do B scan if in the case of advanced cataract where the fundus cannot be visualized. That's when we do B scan. And some for measuring the IOL power, we see the keratometry. Keratometry is the corneal curvature, and then axial length, the length of the eyeball, in order to calculate the intraocular lens power. So axial length is measured by A scan. This is A scan, this is B scan. So A for A scan is for axial length, and B scan is for all these posterior retinal pathologies, all these things we see by B scan. So this is basically a single axis. This is by two axes, x and y axis we will get. This is like a 2D picture. This is like a single line. Then coming to the types of cataract surgeries. We will go ahead with history. Like first is the couching method, which is pushing the lens backward. That is historical. That's been done long back. Shushruta did that. So now coming to the proper surgeries. First is the extracapsular cataract extraction without placing intraocular lens. That's the first surgery that we did. And then intracapsular cataract extraction. That is we use a cryoprobe. Like in this case, this is the cryoprobe, and we keep it on the lens and we remove the entire lens with its capsule. This is done only in case of subluxated lens, because the modern technology, what we do is like we will place a lens. We don't take the capsular bag, because we place the lens on the capsular bag. So we have to salvage the capsular bag, that is the posterior capsule and part of the anterior capsule, everything, so that we can place the intraocular lens. But here in this case, in intracapsular cataract extraction, we remove the entire lens. That is done only in the case of subluxated lens, because we cannot salvage the capsule. So that's why we remove the entire thing total. So coming to the next procedure, which is extracapsular cataract extraction with the posterior capsular intraocular lens implantation. Posterior capsular intraocular lens implantation. So after a large anterior capsulotomy, what we do is like large capsulotomy is done after extended limbal incision is completed, and then lens is expressed by bimanual technique. This you can see there is a pressure that the doctor surgeon puts here, so that the lens comes out in this way. So what happens is there is a big free space for the lens to come out. It will come out easily, but the problem here is we have to suture a lot of sutures we have to make, and because of that there might be like a lot of corneal astigmatism. That is the only issue with this extracapsular cataract extraction. Otherwise it's a good procedure. And then small incision cataract surgery, that in India we do a lot of this, because we have to there is a voluminous patient, there are a lot of patients, so we have to make a tunnel, and then this is the tunnel how it is made. And then by manual aspiration, we have to express the nucleus and then manual aspirate the cortex and implant IOL. The visual rehab is comparative to phacoemulsification, but this is very advantageous in the case of developing countries. That is because it's very faster, quicker surgeries can be done, and need for expensive technology is not there, because phaco and all we need a phaco probe, all those things. Here with the basic simple instruments we can do this procedure, and we can get almost 6/6 vision on par with phacoemulsification. So for high volume camp surgeries and all, we prefer SACS. Then comes the phacoemulsification. In this technique, what we do is like the lens is emulsified and aspirated through the ultrasound probe. This is the ultrasound probe. This is how it is broken down and then it's eaten up by the phaco probe. So the incision is very small, 2.8 to 3.2 mm. We can place a foldable lens, which we can either fold it and place it, or we use a rollable lens also. This is how small the lens is, tiny the lens is. So now we need to know the standard surgery is phacoemulsification. So when we need to know what are the steps that is involved. So first we have to put an incision and then wound construction. This is how it is done. Wound construction is done. Then we have to remove the capsule, that is continuous curvilinear capsular excess, CCC we say, with a keratome or with a Utrata forceps. We do that, and then hydrodissection. This is how it is done. That is to separate the cortex nucleus away from the capsular bag. Then we do the phacoemulsification, that is we'll break it, separate it, all those things, and then eat it up, all these things. Then removal of cortex, lens cortex, and then we'll place the IOL. This is how it is after placing the IOL. So after completion, we'll do hydro sealing. We inject saline on the open wounds. So now the latest technology is FLACS, that is femtosecond lasers assisted cataract surgery. This is how it is computerized. If you get an image question like this, what is this? It is basically FLACS, which is femtosecond laser assisted cataract surgery. What we do is like the capsular excess is being done by the computer. The emulsification part of it, fragmentation is done by the computer. The laser does it, and then using ultra short pulses, which is 10 to the power of -15, and other things like the incision, the capsular excess, and the phacoemulsification part of it is done by the femtosecond laser. Only what we have to do is like just go inside, aspirate it, and then place the IOL. That is how it's easier for the surgeon. This is highly expensive because we need two separate rooms, surgery, operation theaters, and then we need laser, femto laser. Very expensive. Not all the centers have this, but the precision is very good and it's a lot easier for the cataract surgeon. So coming to the IOL calculation, SRK2 formula is being followed in the case of 22 to 25 millimeter of axial length. So the axial length should be less than 25 normally. The formula states P is equal to A minus 2.5 L minus 0.9 K. This you have studied in your theory exams and all. A is the constant that is given in the lens box itself, and L is the axial length, whatever the axial length of the patient, and K is the keratometry of the patient. You have to just know the name of this formulas. Hofer formula for hypermetropia. We can remember it as H and H. And then SRK-T formula, it is used in myopic patients if the axial length is more than 25 millimeter. And Hygis and Holiday 2 for post-refractive, that is LASIK or radial keratotomy. All these things you can use Hygis or Holiday formula. Then types of IOL, there are two types basically, rigid and foldable. So rigid is made up of polymethyl methacrylate. It cannot be injected, it has to be inserted. So in the case of ECC, SICs, we can insert it, but not in phaco, because phaco we need folded or rolled IOL. This for economic reasons they are widely used. We use left and right in our country. And then PCO rates are higher with PMMA lens. So PCO is posterior capsular opacification is there, but that doesn't that's not a big deal because we can do yak capsulotomy and clear that off. It's not a big complication. Some surgeons prefer heparin coated IOLs in uveitic eyes. See, in the case of uveitic eyes, foldable lens won't be proper, but rigid with heparin coated is a very good thing, because the patient will have uveitic features later on. That can be prevented with this kind of a PMMA. That is the only great indication. Otherwise, it's for CAM patients. Then foldable lenses, it's made up of acrylic and hydrogels. These are all posterior chamber IOLs which are placed on the capsular bag. It can be either monofocal or multifocal. Monofocal is for distance vision. Since accommodation is lost, we have to use the near vision glasses. For multifocal, there will be separate zones for distant vision, near vision, all these things. The patient can be without glasses for distance and for near. The main disadvantage is glare and halos. This is where in uveitic patients we don't give multifocal. We don't prefer multifocal. That's because of the glare and halos. So we prefer either rigid IOL with heparin coated or monofocal foldable lens. We can try, but multifocal is always not preferred. Accommodative IOL, this is a new one, which is the lens IOL moves in the capsular bag during accommodation to provide good vision. And toric is for if the patient has astigmatism, we call it toric intraocular lens. That is the cylindrical power is incorporated in them. So whoever the patient, as you can see in the spectacles, spherical power and cylindrical power, for those patients with cylindrical power, we can use toric lens. Coming to the complications of cataract surgery, first is the dreaded complications, posterior capsular rupture, but it's not a big deal, but still it's a big complication. But one which is very dreaded is endophthalmitis. We'll talk about it later, and other things are can be dealt with easily. So I'll just enumerate: a rupture of posterior lens capsule, retinal detachment, uveitis, TAS, which is toxic anterior segment syndrome, cystoid macular edema. It's otherwise known as Irwin-Gass syndrome. I think in entrance exam they prefer to ask all these syndromes. So Irwin-Gass syndrome is in cystoid macular edema. That is post cataract surgery. If the patient has cystoid macular edema, it's called Irwin-Gass syndrome. Striate keratopathy, that's because of endothelial damage. This is endothelial decompensation. If there is total endothelial decompensation, then you will have pseudophakic bullous keratopathy, which is a little dangerous condition, and in this case we have to do corneal transplant, which is not good. Coming to complications, first is malposition. The IOL may be decentered, it may not be in the capsule or bag. So there are three types. This is like fancy names: sunset syndrome, like as you can see the sun is here, the lens is called sun here, and then sunrise syndrome, where is it's a subluxated superiorly, as you can see sun is risen, and then windshield wiper syndrome, it moves with the position of the head like windshield wiper. And then posterior capsular opacification, it's also known as after cataract. It is due to proliferation of lens epithelial, migratory lens epithelial cells, LECs we call it, that remains within the capsular bag. It just moves and it forms a opacity on the back of the on the capsular bag. So the posterior capsule behind the lens may opacify months or years after cataract surgery, so leading to visual impairment. What we do is like yak capsulotomy we do, and these two names are very important in your entrance exams. So Elschnig pearls and Sommering ring, these two things are very important. These are the pearls, as you can see, Elschnig pearls and Sommering ring. These are the Sommerings. Okay, this is same like posterior subcapsular cataract, in which I told you already that there will be proliferation of lens epithelial cells, Friedel cells or bladder cells. The same thing here. So coming to endophthalmitis, this is the most dangerous complication, because whatever other complications, we can bring the patient's vision to 6.9 if not 6.6, but endophthalmitis is one condition. Whatever we do, even if we treat properly, the patient might have 260, 360 or even PLPR vision, which is very bad. So it's very important for an ophthalmologist to be very careful with the infection part. This is the most dangerous complication. It's basically purulent inflammation. It's an infection of the coats of the eye, all the coats of the eye except sclera. If sclera is involved, then it's called panophthalmitis. We'll talk about it later. So here, post-op endophthalmitis, it could be either two things. One is early onset and the other is late onset. Early onset within 7 days, which is staph epidermidis, whereas late onset is fungi or propionibacterium acne. These are slow growing infections. And sometimes posterior capsular opacification, if we do yak cap, then the patient might get endophthalmitis, because the propionibacterium acne will get attached to the capsule and it sits there silently. Once you do the yak cap, then it comes out. That is very rarely it is seen. So this is how the patient will be, and the vision will be very dreaded. As you can see, there is cells. I mean, there's a lot of inflammation going on, and here is a purulent suppuration. And we have to dilate and see all the vitreous. If there is exudate there, then it's very dangerous. So how we have to prevent, that is more than important. Main source of infection is through patient's own flora. So we have to irrigate the conjunctival cul-de-sac with povidone iodine prior to surgery. And many of the ophthalmologists prefer prior and after surgery antibiotics, but it's not been proven. But again, it's always better to use antibiotics. Without antibiotics, we'll be like a little guilty about not using it. The patient presents with sudden onset pain, redness, decreased vision. X-rays are seen in vitreous on examination. So the treatment is intravitreal tap, check for the culture, and then intravitreal antibiotics we have to start. If the patient doesn't improve with this thing, then we have to do a pars plana vitrectomy, and then treatment in the case of panophthalmitis is evisceration. So once if intravitreal injection doesn't work, then we have to do pars plana vitrectomy and remove the viral or the bacterial load. Then coming to management of congenital cataract. Cataract is an important cause for the development of stimulus deprivation amblyopia, which is you are preventing the child from getting proper vision. That is, let's say a child is being has closed his eyes with using any method, then the patient might get amblyopia. The same thing falls here also. The cataract acts like a blockade, and it prevents the light from entering. And here the weird thing is that unilateral cataract is more dangerous than the bilateral cataract, because once you use one eye, the brain will get adapted to that and it starts using that eye and forgets about the other eye. So it's very deadly. So you have to be very careful with unilateral cataract. So ideal age for cataract surgery is 4 to 6 weeks. In the case of unilateral cataract, it's earlier the better. 4 weeks is better. So because 6 weeks is the critical period for visual maturation in children, and thus early surgery decreases the possibility of amblyopia. And IOL power selection, here the trick is in a very small children, it's extremely difficult to calculate IOL power, as the axial length and keratometric values are not accurate, because the child grows and the eyeball also grows, the axial length also grows, and also the corneal curvature grows. So all these things will result in myopic shift. So hence under correction is always better than over correction. If you correct it properly, then the patient might get myopia. So we have to under correct and then prevent myopia. So what are the strategies we follow is, like, if the patient is less than 1 year, IOL is avoided, left aphakic, and later on we will put the intraocular lens. If the patient is between 1 to 8 years, IOL is implanted, the power is under corrected. Whereas beyond 8 years, we give the regular correction, because we don't want to deprive the patient of the proper IOL power. So it doesn't grow much after 8 years, so it's better to give the exact value. Then comes our last topic, which is ectopia lentis, which is very important from the entrance exam point of view. Lens is located in a sausage-shaped depression. I told you about patella fossa, and lens separates the anterior and posterior segment of the eye, whereas the iris separates the anterior and posterior chamber. Ectopia lentis refers to a hereditary or acquired displacement of the crystalline lens from its normal position. Okay, it could be either subluxation or dislocation. Subluxation means a part of which lies in the patella fossa, whereas the dislocation means it's completely dislocated from the patella fossa and lens cannot be seen in the pupillary axis. That is about dislocation and subluxation. This difference you should know. And there is something called phacodonesis, which we usually see. We will ask the patient to look that side and then look at the slit lamp. If the lens shakes, then we call it phacodonesis. In that case, we have to be a little cautious, and we might operate. So, congenital causes includes Marfan syndrome, supratemporal subluxation. The exact opposite is homocystinuria, which is infranasal subluxation. As you can see, this is Marfan's supratemporal, and this is homocystinuria, infranasal. Here you can see the difference. There is zonules here, there is no zonules here. So that is another difference between Marfan's and homocystinuria. There will be zonules here, and because the zonules are there, the accommodation is present. Whereas zonules are not here in homocystinuria, because cystine is important in the zonules. Because cystine is absent, there will be no zonules here, and accommodation will be difficult. Whereas Weil-Mershani syndrome, there will be microspheropecia and anterior dislocation of the lens. As you can see, the lens has come out of the posterior chamber itself. Then the other conditions include Ehlers-Danlos, hyperlysinemia, Stickler's disease, sulfate oxidase deficiency, etc. Acquired cases, most common is trauma. That is only MCQ that I can ask you. Ophthalmos, megalocornea, high myopia, pseudoexfoliation, all these conditions can cause ectopia lentis, intraocular tumors, etc. Treatment, spectacle correction. The catch here is there will be lens tilt or edge effect in eyes with mild subluxation. So if either aphakic correction, if the entire visual axis is aphakia, or in the case of tilt or anything, we will give astigmatic correction. Whereas patient, if they cannot be corrected with these measures, then we will go ahead with surgical removal of the lens. And in case the cataract along with ectopia lentis, we remove the lens. If there is any other issues like endothelial touch or any glaucoma, uveitis, any complication this lens causes, then we will do surgically remove and then place another secondary IOL. We will place it. That is, we will place either on the iris claws or scleral fixated IOLs, like that. Not the normal lens, because we have to remove it with the bag. As I already told you, that's how ICC we do, intracapsular cataract extraction. I showed you the picture there. So thank you.